keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Good day and welcome to JACC Imaging at CVN. My name's Tom Marwick, one of the associate editors at JACC Imaging, and I'm here with John Gorson from Pittsburgh. Welcome, John. Thank you for joining us.
Thank you.
We're here to discuss a very interesting paper that's being published in JACC Imaging about the similarities between right ventricular apical pacing and left bundle branch block in terms of ventricular activation. John, can you tell us a little bit about what you did and the patients that you studied?
Yes, Tom. We were interested in getting some imaging quantitation on these patients with right ventricular pacing in comparison to patients with left bundle branch block who are undergoing cardiac resynchronization therapy. And the reason behind that was that even though many centers around the world are upgrading heart failure patients who are RV paced to CRT, they are not included in the current guidelines. So we studied 227 patients with left bundle branch block and compared those to 81 patients who were RV paced. And just so you know a little bit more about the RV paced patients, about half had complete heart block, and another third of those patients had an AV node ablation for atrial fibrillation.
Okay. So you don't always see dysynchrony in the setting, or at least LV dysfunction in the setting of right ventricular pacing. What was the frequency of dysynchrony in that population?
It was interesting. We used two-dimensional speckle tracking, tissue Doppler, routine pulse Doppler, and three-dimensional speckle tracking strain in a subset of these patients. And when we looked at the measures of intraventricular dysynchrony, they're very similar between RV-paced patients and left bundle. Approximately 70% of the patients had significant dysynchrony. Now, when we looked at sites of mechanical activation, which is related, they also were very similar. The only differences were in the site of earliest activation. And we could expect that because the RV-paced patients most often had earliest activation in the inferior and apical part of the septum versus the anterior and basal part of the septum with left bundle branch block. The interesting thing is that the sites of latest activation were uniformly distributed in either posterior or lateral regions of the left ventricle in both left bundle and RV-paced patients.
That's very interesting. So I guess that, one of the troubles that we've had with assessing mechanical synchrony has really been, proving that this is important in terms of altering outcome. Do these groups of patients behave the same in terms of their subsequent outcome?
That's a good question. Of course, we make these observations, but do they mean anything if they don't translate into patient outcome? We looked at outcome in two ways, straightforward ways. One was ejection fraction response. And the ejection fraction response in the left bundle patients was nearly identical to the RV-paced patients, going from an mean EF of 24 to 33% in the left bundle branch block patients and 24 to 32% in the RV-paced patients.
So very similar, in fact.
Very similar. And then we followed these patients, a subgroup of 234 patients, over about 5 years to look for the hard outcome, hard endpoint of survival free from transplant or left ventricular assist device. And the Kaplan-Meier curves were nearly superimposable. So the long-term outcome was also very similar.
That's very interesting. So one aspect of the paper that I found really interesting was the use of 3D for doing some of this evaluation. Can you comment on the feasibility of this and then any differences that you saw between techniques?
The 3D technique is the newest. It acquires a three-dimensional pyramid of data where you can track the speckles throughout three-dimensional space. And it turns out to be a nice match to look at mechanical activation. And the idea with this is, first of all, to document the patterns in the different types of patients. And then the future hope is perhaps to look at sites of latest mechanical activation to perhaps guide the electrophysiologist if more than one coronary vein were feasible.
Okay. So I guess the final question here is really, what do you think the clinical implication of this is? Do you think that this validates the process of changing these people to BiV devices, or should there be a selection process done on the basis of mechanical synchrony?
I absolutely think that these data extend and support work of others that upgrading patients who are RV paced to CRT, if they have low ejection fraction and heart failure, that it's justified. As far as selecting patients based on presence or absence of mechanical desynchrony, I don't think we're there yet. I think more work needs to be done, and there is continued work in this area, and maybe for the future this will be an application.
Okay. Thank you very much, John. So just to summarize, this I think is a really interesting paper about how we should think about approaching patients with right ventricular apical pacing and the prevalence of desynchrony and its consequences in that group. And I would really commend you to look at the paper. Thank you for joining us on JACC Imaging.